Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. One of the many great things about being a rheumatologist is that there really are few emergencies in our field. We don't typically get called at 3 o'clock in the morning because a patient is having a flare of their rheumatoid arthritis or that somebody's having acute gout. In fact, most of our diseases aren't life-threatening, and our armamentarium of drugs has really enabled many patients to live quite well in remission. But of course, sometimes patients do get really sick and we have to act quickly. This is especially true in those that develop Macrophage Activation Syndrome, or MAS. This is a cytokine storm that often affects people with systemic juvenile idiopathic arthritis or adult onset Still's disease, people with lupus, and some other rheumatic diseases. More recently, we've seen similar cytokine storms affect those with COVID-19 pneumonia and multisystem inflammatory syndrome in children following COVID infections. In today's episode, I've invited Dr. Lauren Henderson to discuss what macrophage activation syndrome is, how to diagnose it, and the medications used to treat it. Dr. Henderson will also shed light on how different specialists have been using different names and different treatments to address the same entity, as well as her efforts to bring everyone to the table to formalize a process for evaluating and treating these patients with activation syndrome. Dr. Henderson is a pediatric rheumatologist at Boston Children's Hospital and assistant professor of pediatrics at Harvard Medical School. She specializes in treating children with complex autoimmune diseases and has led local and national efforts to improve the diagnosis and management of patients with MAS and other hyperinflammatory syndromes. She's a true physician scientist and spends a chunk of her time in the lab studying the role of T cells in children with systemic JIA. Hope you enjoy our conversation. Lauren, welcome to the show.
Hi, John. I'm really glad to be here to talk about my favorite topic, MAS and cytokine storm.
Fantastic. There's been a lot of excitement, a lot of misunderstanding about MAS, macrophage activation syndrome. So I thought it'd be great to start. What the heck is MAS?
I think that's a good question. I think there are a couple points to think about when we think about MAS, macrophage activation syndrome. So one is that it's really like a hyper-inflammatory response. It's inappropriate. It's too much exaggerated inflammation. And it's so exaggerated that it's really causing damage to the body, affecting multiple organs in the body. And this exaggerated inflammatory response is caused by really high levels of inflammatory cytokines, activated cells, immune cells called macrophages, and also T cells. So I think those are the general points to think about MAS. But what's difficult about it is that the nomenclature in this field is really confusing. So a lot
super
of people
confusing
call this different things. Yeah.
Yeah. So when you hear MAS, sometimes you hear about HLH, cytokine storm. So what's the relationship between all of those terms, MAS, HLH? Is it all cytokine storm?
So I think this field, and there have been kind of articles opining about this, the field has a little bit of a mess on its hand. As the nomenclature or the names that we use are really confusing.
Okay.
And I think part of the reason is that different specialties in medicine took care of this and named it different things. That's a long time ago. So a long time ago, rheumatologists would manage macrophage activation syndrome in patients with rheumatologic conditions, and we called it macrophage activation syndrome. And our group kind of coalesced around that term.
Yep.
At the same time, hematologists and oncologists were treating, HLH and, in patients with genetic conditions, and they called it HLH. That's the terminology they used. So I think part of the problem is that different specialists are kind of talking in different language, often about very similar things.
Got it. So is it the case that various different processes all lead to this, cytokine storm, whether it's infections, rheumatic diseases, malignancy? Is that why different people sort of see it in a different perspective? Because, we take care of the patients with systemic JIA that develop MAS, and maybe the oncologists have practice, in patients with malignancy.
Exactly. I think the way that I like to think about it, some people might argue with this a little bit here and there, but it's really a final common pathway that results from many different insults. Okay. You can have a underlying genetic condition. You can have a really severe infection. You can have malignancy. You can have a rheumatologic condition. And for some reason, your immune system gets extra activated, producing a lot of cytokines, a lot of activation with macrophages and T cells. And you can kind of get this final common pathology where there's just way too much inflammation. And now the inflammation that your body is making is actually the problem, not the original insult, like not the original infection or cancer.
Got it. So what's happening inside the body that you're having this inflammation that you're unable to turn off? What's the mechanism behind that?
I think that's a good question. So I think in different conditions, there's probably different factors that are driving this, right? So you can have a genetic condition where you can have defects in something we call cytotoxicity. So that's the ability of your T cells to kill other cells that are infected, and NK cells too. And if you can't do that, your immune system just can't shut off. So that can be one big driver in some people. In other people,
so you lack the brakes in stopping the immune system. Yep.
Yeah, because you can never really eliminate an infection in cells, right? Your T cells are, there's a class of T cells called executioners. Their job is to get rid of infected cells. If you can never do that, like the infection never goes away, right?
Yeah.
Get antigen stimulation, continued activation. But in other people, that process is just fine. And they just have a lot of inflammation, like our kids with systemic juvenile idiopathic arthritis. They're just really inflamed. A lot of IL-1, IL-6, these inflammatory messages. And that chronic activation can lead to MAS. And then really bad infections can like the classic one is mono. If you are unable to handle mono appropriately, you can get this as well. So all of these things can kind of feed into the right host to lead to this final common pathway that's really disruptive and can actually be more threatening than the original problem.
Got it. So in terms of risk factors, you mentioned a couple of things. You talked about genetic disorders, and then you talk about patients with rheumatic diseases like systemic JIA. What other risk factors have been identified that may predispose somebody to develop MAS?
Yeah, I think this kind of goes back, maybe to take a step back with genetic risk factors. I think this kind of goes back to what we talked about, the different fields. So, a long time ago, the hematologists and oncologists saw patients with what they called familial HLH, which means genetic HLH. And, that was thought to be like a purely genetic condition a long time ago. So these patients often, not all the time, presented in the first year of life, and they had defects in genes involved with that cytotoxicity pathway, that T cell pathway that's important for eliminating infected cells. And so they thought that this was all genetic, and it was genetic familial HLH. And then at the same time, a long time ago, the rheumatologists were treating macrophage activation syndrome and rheumatologic conditions, and that was thought to be totally not genetic, no genetic cause. But over time, it's turned out that these patients that we see as rheumatologists, the systemic JIA patients, a lot of them can have variants in like one copy of familial HLH genes. So typically, if you have familial HLH, you would have 2 abnormal copies, total defect. But for patients with rheumatologic conditions, even having one copy seems to put you at risk. So then the question is, there's obviously a genetic component to our rheumatologic macrophage activation syndrome too. So it's all kind of, this is what's confusing about this field. It's kind of all kind of starting to crisscross over each other, where you can't really say one is purely genetic and the other is not. If that makes sense.
Yeah, absolutely. So it seems like it's like many of our other rheumatic diseases that it's both, so there's maybe some genetic predisposition, but maybe some other environmental triggers that may cause disease. How did you become interested in studying macrophage activation syndrome?
Yeah, I think that's an interesting question. So I think some of the most salient experiences I had is when I was a resident. So this was a while ago. And this was still back in the time where hematologists, oncologists, and rheumatologists really didn't communicate much about these patients. They didn't really see that they were similar. And we had a couple patients when I was in residency come in and they were really sick with hyperinflammation. So rheumatologists would call it macrophage activation syndrome. The hematologist would call it HLH. And these patients were sick, and the hematologist, oncologist, and the rheumatologist really couldn't agree on what to do because they weren't used to communicating with each other, and they were used to managing this condition very separately, different medicines, different approaches. And it really felt as a resident pretty terribly when you had a very sick child, because these children are really sick, and like the teams can't agree on what to do, but something needs to be done fast. And so that often would leave teams upset, parents confused, and I wanted to make that better. And, that made me really interested in like, how can we fix this? Because we all want our patients to do better. And we don't want to wait till the last minute when someone's really sick and to be disagreeing. Like, wouldn't it be great if we could just have a plan ahead of time of what we're going to do so we don't end up in that situation? And so that's actually how I got involved in doing a lot of the work around multidisciplinary teams and coming up with consensus on how to treat patients with HLH and MAS.
Got it. Because I guess at that time, the hematologists were doing chemotherapy with patients with HLH. And how were rheumatologists managing these patients?
Yeah, so hematology oncology, had very clear protocols for patients to get chemotherapy like etoposide. And often, reasonably so, the hematologist and oncologist would not start chemotherapy right away, right? You probably have to be pretty sick before you're going to give a child chemotherapy.
Yeah.
On the other side, rheumatologists started to have other treatments that we would often start earlier, like before a child met full-blown criteria for HLH. So we would be very anxious to intervene with our medications that are much less toxic. Things like steroids, things like cytokine inhibitors. Often anakinra is used. It inhibits IL-1. And so there would be some disagreement if we should treat early with some of the rheumatologic medications or kind of sit and wait until a child got sicker and do etoposide. And both sides of the fields really weren't familiar with the other's medications. And that was part of the communication problem.
Yeah.
And that's often what the disagreements were about.
So how did you try to find a solution to that problem? Because I know, so that was sitting in your brain back when you were a resident.
Yeah.
And now you're a full-blown attending. So how did you attempt to try to reconcile those differences over the last few years?
Well, we were lucky at Boston Children's Hospital where I work. There was a kind of structured way to solve these problems of difficult to manage conditions where you don't have a lot of evidence of what's best. And it was called an evidence-based guideline, or an EBG. And our quality improvement department at Boston Children would help teams get together to try to build consensus to come up with a good plan of what to do.
Sounds like the perfect target for that program.
Yes, it was. It was perfect for us. So we, in the end, basically got everyone in a room once a month for 8 or 9 months. And we kind of just talked about, like, what's our plan going to be? Like, who's going to be called the first call for HLH-MAS? Because sometimes it would be hematology and oncology, and sometimes it would be rheumatology. And then depending on who got called, totally different things would happen. It would drive the house staff insane, right? Who's going to be called? How are we going to do the diagnostic workup? And what treatments are we going to start first? And then, what's going to be the order of things that we're going to do? And through talking with each other over, that extended time, face to face, we really came up with kind of an algorithm or plan of who's going to be the first call, what is the diagnostic workup we're going to do, and what treatments are we going to start first? And if they don't work, what will be our second level treatment, so that we have a kind of like a roadmap before we even start or see patients that we all agree upon.
Great. So, this was called an evidence-based guideline. So how much evidence was there to
Yeah.
direct your workup and
Yes.
treatment plans of these patients? Or did you have to come up with some of that on your own?
At the time, a lot of the evidence was from the hematology oncology group where they,
Mm,
had done these large trials with chemotherapy. And there was probably less evidence on the side of rheumatology to use things like steroids and anakinra. These were all based on the kind of small case series in patients with systemic juvenile idiopathic arthritis. But part of this was also like expert opinion and experience and kind of consensus building. And, I think in the end, what we learned was that the oncologists don't like giving chemotherapy for HLH, right? They
yeah.
don't want to do that if they can avoid it. And the rheumatologist had something to offer for first level, which would be like steroids and biologics like anakinra that are less toxic. And we kind of agreed that why don't we try that first? And then if it doesn't work, we have to be in really close communication with our oncologists and hematologists to go to the next level, because it's very important that if something doesn't work, you move on from there. And at the end, I think people were really happy with this solution because it often gave the patient something very quickly that we could intervene with that wasn't as toxic as chemotherapy.
So how are you identifying these patients in the hospital? How are you teaching house staff? Because I imagine those are the ones that may say, oh, this is a patient that would need this, that would need to follow this evidence-based guidelines for, right? So how are you training house staff to use your guidelines?
John, I think that's like a great point, because if you don't know what's out there to treat, you can't treat anyone with HLH and MAS that you haven't identified.
Yeah.
And the thing that's tough about HLH MAS is that it hides, right?
Mm,
So it can just look like, oh, this person has a bad infection or this person has malignancy. But really, and you blame all the inflammation on that. But really they have HLH MAS and you've missed it. And you
mm,
haven't really addressed the thing that's really going to cause harm to the patient. And so I think that takes a lot of work to have people on the lookout for this so that you can get these patients early, right? So if you get the patients earlier, you have a better chance of intervening with less toxic medications for better outcomes. And I think this is somewhere, and it's controversial, like where the pediatricians do this really well. So I think because of the experience with pediatric rheumatology with systemic JA, our house staff is really familiar with MAS.
mm.
We see systemic JA patients in MAS a lot. So they really know that if a child comes in with unexplained fever for a really long time, inflammation that seems out of proportion, part of our workup of this fever of unknown origin in kids is to get a ferritin. And you'd be surprised, like we end up getting, a good amount of patients that they're identified that way. And it's because our house staff are really, really aware and able to identify these patients and get them to us really early. So we're often treating patients here, within two days of a hospital admission when they don't have a known diagnosis of HLH or MAS, which is pretty good. And that's really because of our house staff and their knowledge about being on the lookout for MAS and HLH.
Great. So you mentioned a couple of things: fevers, especially fevers of unknown origin, hyperferritinemia, like 500, 200, 5,000.
Yeah, surprisingly, in the pediatric side, there's not so many patients who have ferritins over 500. So usually we say that might be the time just to give us a call to see if we want to do further checking. But in general, patients who have true HLH-MAS is much higher than 500, right? It's in the thousands. But I think the key really is that like they're going to have fever,
Yep.
and it's really kind of out of proportion to what you would expect. Like they're sick enough with fever to be admitted to the hospital, and the cause isn't clear, and you're starting to see a lot of organ dysfunction. So that is really not explained by how they should be presenting. And there are other clues too. So like a falling complete blood cell count. Like if you're inflamed, your white blood cell count should be high and your platelets should be high. If those are low, that's a little weird. Very high inflammatory markers like
Mm-hmm.
CRP, but a paradoxically falling ESR because the patient's coagulopathic, liver dysfunction, and then ferritin. Those are the things that we often will look at for our second pass.
Got it. And then when you get called, are there additional things on the history, the exam, or labs that you do to try to sort of support the diagnosis of MAS?
Yeah, so, first kind of an exam, because sometimes if they have systemic JA, right, they might have rash that we would see. They might have arthritis, hepatosplenomegaly, large lymph nodes. And then, the first round of blood tests is pretty easy for anyone to get. We kind of went through it. The complete blood cell count, looking for falling counts, high liver tests, coagulopathy, high levels of inflammation, high ferritin. But then there's a whole lot of other fancier tests that you can send to kind of look for this fingerprint of cytokine storm. So you can get a soluble IL-2 receptor, which is a sign of T cell activation. Both MAS and HLH is driven really in large part by interferon gamma.
Mm.
And there are now send-away tests where you can really look at that for signs of interferon gamma, something called a CXCL9. And then in systemic GA, IL-18 is really associated with MAS. That's an inflammatory cytokine, and we can send that too. And those tests actually help us a lot to know how much cytokine storm, right? How much cytokine activation we have and T cell activation we have.
Got it. But often those tests, may take days,
Yeah.
sometimes weeks. So you often have to act ahead of time. I imagine part of the sort of workup for these patients is looking for triggers, right? Like, what's going on? Was there an infection? Is there still an infection? Is there malignancy? Is there SJIA? How do you manage that evaluation? Because I find often that's the hardest thing. It's like, yeah, you may identify MAS, but what's behind it?
Yeah, I think you're completely right. If you don't find out what's behind it and treat that, the MAS and HLH is never going to go away, right?
Yeah.
Like the inciting trigger is really important. You have to treat both, like what caused it, and then the overwhelming inflammation's coming from that trigger. And so that's really where you have to rely on your colleagues. And so part of our algorithm is, if you're concerned for infection, calling infectious disease, right? Making sure you've ruled out mono or EBV or other infections. If you're concerned for malignancy, really making sure that you have our hematology oncology group ruling out things like T-cell lymphoma and those types of things. And then even like patients can have immune dysregulation, like immunodeficiencies, underlying genetic immune problems that predispose them to this. And so having our immunology colleagues with us too, you really kind of have to have a team of people to roll out these things. But you're right. Sometimes even while the diagnostic workup is happening, like you don't have a choice. You have to kind of move forward with treatment because the patient's so unstable. And really there, like the trigger for treatment we find is trends, like so trending over time. If you're seeing like a steady trend of worsening, right? Like patients not doing well, more organ dysfunction, fevers are ongoing, cell counts keep dropping, ferritin keeps rising. It's not something that you're going to just sit and watch. It's time to kind of intervene with something while the diagnostic workup is ongoing.
Yeah. You mentioned earlier that many of, at least patients with SJIA may have some genetic predisposition. So do you tend to send genetic testing in all patients with MIS or only a subset of patients like those with SJIA?
Yeah, that's interesting. So I think part of our algorithm is that if you're coming in with like MAS, you should get genetic testing. So we usually do a primary immunodeficiency panel. I think maybe not everyone follows that for every systemic GA patient. But when we look back at our experience here, when we did that, when we looked at like who was getting genetic testing, we found that in about a quarter of patients, we identified some type of underlying genetic factor that contributed to the presentation, which I think can be helpful in terms of prognosis, what treatments are you using if you're going to keep the patient on treatment.
Fascinating.
So we do that pretty routinely.
Okay. And then just roughly in terms of treatment, you mentioned a couple of things. You mentioned steroids and then cytokine inhibitors like anakinra. So do you use usually both of those at the same time, sort of early on, or do you sort of do one first and then build on the other?
I think most of the time, if you're in kind of full-blown HLH-MAS cytokine storm, you're probably going to need steroids. They're usually your friend. And we usually use pretty high doses of steroids, 30 milligrams a kilogram for a child, or 1 gram of methylpred. And then that usually works pretty well hand in hand with a cytokine inhibitor. Typically, we start with anakinra because it's often safe if you're still working up an infection. It was studied in sepsis and, patients who were actively infected. And we have a long track record with it. It has a fast on and off so that if you run into trouble, you could stop it pretty quickly. And then really we would want to see the patient respond. And it needs to be like a pretty robust response. Like there's no real such thing as partially treated HLH-MAS because it's just going to keep going, right? So you need to have a very good response pretty quickly. And if that's not the case, then often we will go on to other cytokine inhibitors. And there's some really new, interesting medications out there. So we talked before that it seems that HLH and MAS, that interferon gamma is an inflammatory protein and signal your body makes that really drives HLH and MAS. And there's emapalumab, which inhibits interferon gamma. That's been studied in familial HLH and been approved for use for familial HLH. So we've used that. And then we also use JAK inhibitors, so especially like JAK1 and 2 inhibitors that block interferon gamma signaling, like ruxolitinib. So those are often our second line at our institution. And then, of course, if we're going through these types of medicines and not having a response, we're really in close communication with hematology oncology in case we do need to give chemotherapy. Because the worst thing I think we can do as rheumatologists is offer our medicines we're not getting a response and delay definitive treatment if we need chemotherapy with etoposide.
Got it. And one thing, we didn't discuss was the role of a bone marrow biopsy. HLH is called that because you see hemophagocytosis in the bone marrow. So is there a role for bone marrow biopsy in patients presenting to the hospital with MAS?
Yep. And I think this is different a little bit with adults and children. So children, MAS and HLH is much more likely to be triggered by infection or things like systemic JA. So if we have a patient who really looks exactly like systemic JA, has arthritis, fevers, and MAS, we often don't do a bone marrow transplant for those patients.
Bone marrow biopsy.
Bone marrow biopsy for those patients. But for other patients where there's concern for infection or malignancy, it's really important, especially if you can do it before steroids are started.
Got it. And then I don't know if it was a mix-up, but you mentioned bone marrow transplant.
Yeah.
So is that a potential treatment for some of these patients, especially those that have genetic disorders?
Yep. So that's why it's helpful, right? If you identify a genetic condition with genetic testing, because there are some patients with traditional familial HLH, so that present later, not in the first year of life. And the definitive treatment for that is really going to be a bone marrow transplant because they're going to get recurrent episodes of HLH and MAS. There are also patients with immune dysregulatory syndromes like immunodeficiencies with a genetic condition that, again, they're probably going to continue to have abnormal immune responses and they need a bone marrow transplant. Most rheumatologic patients we really can manage with rheumatologic medications or at worst, etoposide. And then once we get the rheumatologic disease under control, HLH-MAS is much less likely to occur.
Got it. And, can you tell me a little bit about the long-term prognosis on, patients with MAS? Is this a one-time thing that, that they recover and then they're totally fine? Or can this be a continuing or require continuing medications? Or would they be susceptible to MAS later down the road?
I think that's kind of where I think we need more research to understand this. So there's certainly patients where this is a monophasic one-time thing. And it could be, a child who gets EBV and they have a really robust response to EBV. We can get their inflammation under control and they, for the period of time we follow them, it's not a problem again. We also have rheumatologic patients who present in MAS, but once we get their rheumatologic condition under control, when they don't have that tonic amount of inflammation around, they don't get MAS again. But then there's other people we really don't know, right? If you identify a genetic predisposition, then that's concerning. And then there's other people that we don't know how to predict that. And I think that's where we need more research to help guide our treatments. For those patients who end up, we decide not to do a bone marrow transplant or watching closely, we really have to make sure that they understand what they have, right? So that, I've had patients represent maybe 10 years down the line with another case of HLH-MAS, and they didn't really remember that they had it when they were 2.
Oh, wow.
Right? So there has to be some education. Hey, if you ever get admitted with fever, you need to tell someone that you've had macrophage activation syndrome before. Get a rheumatologist, or someone, a hematologist or someone to come and see you. Don't just have fevers where no one's checking this. So part of that's education too, to make sure that the patients know what they have and that they might be at risk for this in the future. And we can't predict it sometimes.
Got it. So shifting gears a little bit, I think if you had asked anybody about sort of layperson about cytokine storm or even macrophage activation syndrome before 2020, they would have had no idea. And then COVID happened, right? And we were seeing patients with what looked like a hyperinflammatory syndromes that may have been triggered by COVID. Can you tell me a little bit about your experience of treating patients with hyperinflammatory syndromes during the COVID pandemic?
Yeah, I think, it's interesting. It's crazy to think back to that time.
Yeah.
Like for us, floor fell through the ground or whatever you want to say in April of 2020. So at the beginning on the pediatric side, COVID really seemed to be not so much an issue for our pediatric population. So most healthy children were managing COVID just fine. There were no reports of really high rates of severe COVID pneumonia in that population. And it really seemed like an adult or older adult problem. And then suddenly in April of 2020, during the first wave, after COVID had swept through Europe, in Italy and the UK, they started reporting that children about a month after their COVID infections were developing a really marked inflammatory response. So that about a month after their COVID infections, they'd have fevers, rashes, red eyes, red lips, cardiac dysfunction, so they present in shock, and multiple organ dysfunction, a lot of GI symptoms, and coagulopathy. And it was clearly linked to COVID, the prior COVID-19 infection. A lot of them had COVID antibodies, so they had been exposed. And this ended up being called MIS-C, multi-system inflammatory syndrome in children. And it really was surprising to us because we didn't really expect this to happen when the pandemic started. And I think that pediatric rheumatologists were really kind of in tune to this because this looks a lot like some of our conditions that we treat. So macrophage activation syndrome and systemic JA, Kawasaki disease, which is another pediatric disease, which is a vasculitis that can present very suddenly. And so I think we were called to respond to treat to these patients because of our experience with things like MAS and because of our experience with things like Kawasaki disease. And so it turned out that these patients respond very well to a little bit of steroids, sometimes IVIG, so pooled immunoglobulin, and other medicines that block cytokines like anakinra or infliximab. And because of our experience as rheumatologists with those medicines, we were often called to treat those patients. And I think interestingly on the adult side, which it turned out that patients who have really, really severe COVID pneumonia also had hyperinflammation, different than MIS-C, that responded to immune modulators like baricitinib and steroids, dexamethasone. And these are all medicine that rheumatologists are familiar with using.
Yeah, I sort of experienced both sides of this.
Yeah, I bet you did.
And it was fascinating how involvement of rheumatologists into, this infectious, right? COVID-19 is an infection, into either related to acute infection or sort of post-infectious sequela was really fascinating. So, a couple of questions, how did your work on MAS and especially establishing guidelines and practice guidelines affect sort of how, the hospital began to treat children with MIS-C, if at all?
Yeah, so I think, like exactly what you say, I think a lot of our experience with these hyperinflammatory MAS kind of conditions really primed us to be able to respond to this kind of sudden presentation of MIS-C, COVID. So first is the idea these patients are really sick and you have to act really quickly. And we already know those lessons from MAS. Like we're used to when kids come in with MAS, they're sick, you have to intervene quickly, you have to provide immunosuppression quickly, you cannot wait. And that certainly was the case with MIS-C patients. Second, because you have to act so quickly, you really need to have a plan, like who's going to respond, who's going to give the medicine, who's going to be able to do that. And I think our experience with developing these algorithms and pathways, we really quickly, not just us at Boston Children's, but many other pediatric institutions developed very quick algorithms of how to manage MIS-C based on our expert opinion, because there was no data at that time. This was. And so because there's no data, then you really need to have a plan that you all agree on. And so many of these hospitals developed algorithms, who's going to be called, which patients, what criteria in patients that they meet to be called, and what medications are we going to use. And because the patients looked a lot like Kawasaki disease, we chose steroids and IVIG, which many other places did, and actually, fortunately, worked very well for patients. And I think this is probably similar in adult COVID, right? There was algorithms that were developed pretty quickly, probably at adult institutions as well, to help guide people on what to do when there's not much data available.
Yeah, it was really interesting to see how it varied between hospitals, right? Some hospitals, rheumatologists, like at Children's, rheumatologists were called in sort of every patient with, MIS-C or hyperinflammatory syndrome, whereas in other hospitals, it was the pulmonologist or infectious diseases that were managing the cytokine blockers.
I think there's no one way to do it. The point, it doesn't have to always be rheumatology. It can be infectious disease or another specialty. But the point is you need to know who to call, and the people need to be able to own that and take responsibility for that. And if you plan ahead, I think that's the most important thing, that you have a plan and people know who's going to do what. And it doesn't have to be the same way at every place.
You did a fantastic job at Children's. We're getting everybody together to coming up with these guidelines. That certainly has improved the treatment of these patients within children's? Well, actually, I'm saying that. Do you have any evidence that it has improved the treatment of children with MAS being admitted to the hospital?
So I think that's tricky. It's really hard to measure outcomes, right? Because this is more quality improvement research where you don't really have a comparator group. And I think that's a fundamental question. It's like, how do you prove that like using multidisciplinary teams or an algorithm is really helpful? Like,
right.
Where are your outcomes data? We've done some work comparing patients before this algorithm was implemented to after. And it did seem that patients were identified more quickly, got HLH-MAS treatment more quickly. There were fewer deaths. But, some of this is also compounded by the fact that the treatments offered were a little bit different over time. And over time, we've gotten better at treating it. So it's not the perfect comparison. But I think there is some evidence that it is helpful, at least at our institution, compared to historic controls.
And people listening out there, how can they implement something like what you did at Boston Children's in their own institutions, whether it's for, MAS, HLH, or for other of the complex sort of syndromes that require multidisciplinary teams to treat?
I think that's an excellent question. So I don't think there's any one right way to do this. I think the important thing is to have a group of people who are dedicated to improving management of these conditions get together and agree, develop consensus and agree on how your institution is going to manage this. And that kind of discussion and consensus building is really important and really can lead to long-term improvements on how you're going to manage these patients. I don't think there's one right way. Like there's some teams that are very centralized, that have, a very clear algorithm. That tends to be at big academic centers where there's more people, more resources. And then there are other teams, even at smaller centers, non-academic centers, that are a little less formally organized, but still probably are effective. I also think that this is, something that's important for like institutions to provide buy-in, right? Because you kind of have to work with your institution to figure out like how would billing work? How are these teams going to come together to manage these patients? Because it's a little bit of a different model than traditional care where you're consulting one provider. But I think that's something where like institutions really need to provide buy-in and resources so that clinicians can do this, because it really does seem to help patients who have these present critically ill that really need very quick intervention and require many teams to manage them.
Yeah, it's great also. I've been impressed with some of the work that you've done and manuscripts you've published on these topics, and also working with like the American College of Rheumatology to help provide guidelines to other institutions and other rheumatologists and helping them, manage patients with these conditions. Is there anything you're excited sort of in the future, anything you see coming down the pike that may help us with either diagnosing or managing children and adults with MAS?
Yeah, I think it's a really exciting time. I mean, first, there are a lot more biomarkers being identified. Things like what we talked about, CXCL9, IL-18, these are all immune fingerprints, traces of macrophage activation syndrome. And it can be really helpful when you're not sure, is this patient just have an infection or is it an infection plus MAS, right? And so I think the more biomarkers we can get that are actually clinically available, so some of them are really just available on a research basis or hard to get, the turnaround time is long. I think over time, as we can get some of these lab tests that are clinically available and rapidly return, it's really going to help us manage and identify patients. And then we have a lot of treatments available now, right? So we have a lot of different cytokine inhibitors, JAK inhibitors, chemotherapy. I think we need to have better biomarkers and research about which patients should get which drug up front, right? So right now we're kind of giving everyone at our institution, most people start with steroids and anakinra. And maybe there's a way to recognize patients at the beginning that they're not going to respond to that regimen and they should just really go to something else. And then there are groups of patients that traditionally just have not done well with anything. And that's particularly malignancy-associated HLH. It's extremely difficult to manage. And I think that we increasingly need to kind of have better ways to treat those patients so they have better outcomes.
Great. Well, Lauren, this has been a wonderful conversation, and I think it's been really remarkable to sort of see from this nagging question that you had, back when you were a resident about, hey, these patients, we don't know how to manage them, to sort of establishing, an evidence-based guidelines in this hospital, and then working with others to establish national guidelines, with the American College of Rheumatology. It's been really helpful for patients, not just at Boston Children's, but probably throughout the US and the world. So thanks for all the work that you've done and continue to do on these topics. And I really appreciate your time.
Yeah, thanks for having me. This was really fun.
Well, there you have it. I really hope that this conversation has provided you with some insights into macrophage activation syndrome, and may even have encouraged you to establish a multidisciplinary team to help diagnose and manage patients with MAS at your local institution. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org and on your favorite podcast app. Until next time, watch out for those crazy macrophages. And of course, stay healthy.
Loved this episode of ACR On Air? Then be sure to subscribe at acronair.org and join us every third Tuesday for new episodes. Thanks for listening.